Hi, I'm Steve Fife, Infection Control Specialist at MetroHealth Medical Center. I was given that title because my responsibility is to investigate hospital-acquired infections, to teach classes such as this, and to act as a resource for those that have questions about infection control. But infection control is everyone's responsibility. It's your number one responsibility to protect yourself, to protect your family, to protect the patients that you care for, protect visitors. Now, why do I say you and your family? Well, who wants to come into the hospital as an employee and take home tuberculosis or HIV or hepatitis B or pertussis? You don't. So you have to start with protecting yourself. And if you do that, then you'll also be protecting your family, because you're not going to get anything on you, or you're not going to take anything home to them. And you're also going to protect the patients. We have 7 ICUs here at MetroHealth Medical Center. That means we have a lot of patients who are susceptible to infection. Think about the babies in the NICU or the patients up in oncology. Those patients are very susceptible, and it's your responsibility to treat those patients as if they're family. And when you protect yourself, you're protecting them.
In order to protect yourself and your patients, it is helpful to understand the chain of contagion and how to break it. The elements of this chain begins with the contagious agent, which can colonize or infect you and your patients. Many of these contagious agents have achieved the status of superbugs because of multiple resistance to antibiotics and enhanced virulence both in the community and in the hospital. You are all aware of MRSA, VRE, and multiple drug-resistant gram-negative rods, such as ESBL Klebsiella, to drop a few notorious names. Contagious agents also include microbial terrorists which have attacked our patients, both in the hospital and in the community. These include such bacteria as Clostridium difficile, Meningococcus, and pertussis. Also contagious terrorizing agents include viral pathogens, such as RSV and influenza. The next link in the chain of contagion are the reservoirs, where contagious agents live and survive, until they find their next victim. Superbugs and microbial terrorists just love warm, wet, and dark reservoirs to live and grow. Patients and healthcare workers have multiple such hidden caverns, crevasses, and mucous membranes. Here are a few popular dwelling places. Clostridium difficile just loves those cozy bowels, and MRSA is right at home in those roomy nasal cavities, and beta strep is happy as a clam in the throat. Many contagious pathogens can survive on high-touch surfaces and equipment for long periods of time, serving as a reservoir for colonization and infection. MRSA, VRE, ESBL Kleb, and Clostridium difficile are examples of environmental contagious agents. These organisms survive and grow on the fecal veneer and body fluid contamination, on high-touch surfaces and equipment, such as patient charts, privacy curtains, stethoscopes, bedside tables, bed rails, controls on monitors and other equipment behind beds, portable X-ray and respiratory equipment, computer keyboards and telephones. Susceptible hosts are another link in the chain of contagion. You and other healthcare workers are the target of contagious pathogens lurking around the next corner, and every crevasse, ready to attack. Yes, you may be a susceptible host for such contagious infections as whooping cough, tuberculosis, chickenpox, HIV, and meningococcal meningitis, to name a few. Not only you, but also your family, if you carry those contagious agents home to your loved ones. Also, we have many susceptible hosts throughout the hospital, especially in oncology and the 7 intensive care units, such as the neonatal ICU where premature infants are severely immunocompromised. These fragile babies are under attack by superbugs and microbial terrorists, like MRSA, RSV, and rotavirus. It is your responsibility to first, do no harm, and protect your patients from hospital-acquired infections, like ventilator-associated pneumonia and central line-associated bacteremia. The final 3 links in the chain of contagion is the portal of exit, the mode of transmission, and the portal of entry. Here is your greatest opportunity to break the chain of contagion, to prevent the spread of contagious pathogens to yourself, your family, and your patients. Let's consider these 3 links in the chain of contagion as a unit and give a few examples. Note here that the portal of exit is the throat of a patient with whooping cough. The mode of transmission are the droplets being transmitted a short distance through the air, less than 6 feet. Finally, the portal of entry are the nasal cavities of the healthcare worker who has failed to protect himself. Another common chain of contagion is similar to droplet transmission. The portal of exit, coughing, and portal of entry, breathing, are the same as droplet transmission. However, some contagious agents are able to be carried as microscopic particles floating on the air currents, further than 6 feet, thus, airborne transmission, simply, by sharing airspace of a patient with tuberculosis and chickenpox, you can breathe in these floating pathogens. This is especially true in close quarters such as elevators, classrooms, and crowded waiting rooms. Let's consider another example of these 3 links in the chain of contagion. Here the portal of exit is the stool of a patient with Clostridium difficile. The mode of transmission are the hands of this healthcare worker. After handling the contaminated bedpan without gloves and without washing her hands, she delivers food to another patient. She touched not only the food container, but also the bedside table and the hands of the patient. Now the portal of entry is the mouth of the patient. When she eats the food with her contaminated hands, and gets C. diff gastroenteritis, the chain of contagion begins again. The portal of entry could also be the healthcare worker herself when she ate a snack. Let's consider one more example of these 3 links in the chain of contagion. Here the portal of exit is an MRSA pustule. The mode of transmission is direct contact with the hands of a healthcare worker who changed their dressing, not wearing gloves, and without washing their hands. Also, the mode of transmission could be indirect contact, when the MRSA pus contaminates the bed linens, which are handled by the laundry worker without gloves. In both direct and indirect contact, the portal of entry are the hands of the healthcare worker, which has become contaminated. The MRSA then can cause infection or colonization, continuing the chain of contagion. The MRSA can then contaminate the healthcare workers' uniform and equipment. It can spread to patients and can be taken home to their family. Let's consider another chain of contagion often encountered in the hospital. The portal of exit occurs when blood, body fluids, and other potentially infectious material is removed from the body. For example, during a blood draw, invasive surgical or dental procedures, the mode of transmission may be a needle, scalpel, or body fluid splash. The portal of entry may be a result of a puncture wound, needle stick, bite that breaks the skin, and a splash to the eyes, nose or mouth, and contact with non-intact skin.
Ouch!
Common blood-borne contagious agents are HIV, hepatitis B, and hepatitis C. We have reviewed the most common chains of contagion found in hospital settings. However, there are many other chains of contagion, with different modes of transmission with various contagious agents. These include foodborne transmission, such as Salmonella in peanut butter, and insect-borne transmission, such as West Nile virus in mosquitoes, and waterborne transmission, such as E. coli 0157, hepatitis A, and Legionella. Thankfully, these are not often the cause of hospital-acquired infections, because precautions are in place to prevent them.
As you recall, in Canada a few years ago, SARS hit. There was a report that was done shortly after the SARS epidemic was over, and it was entitled The Spring of Fear. Why was that? Well, let me give you the example that they gave of two hospitals. One was in Ontario and one was in Vancouver. On the same day in March, a SARS patient came into their ER. One patient, mind you. In Ontario, there was so much devastation, it's unbelievable. There was 375 infected patients, including 169 healthcare workers. 50% of those that were infected were healthcare workers. 44 were killed, including 2 nurses and a physician. How many cases do you think resulted from the one case that came into Vancouver? None. 0. What was the difference? Okay, let's look at that Spring of Fear and some of the quotes that's from that report. In Ontario, unlike Vancouver, there was a systematic failure to recognize in hospital worker safety the precautionary principle, that reasonable action to reduce risk need not wait for scientific certainty. That's what the precautionary principle states. Perhaps the most important lesson of SARS is the importance of the precautionary principle. SARS demonstrated over and over the importance of the principle that we cannot wait for scientific certainty before we take reasonable steps to reduce risk. Let me give you an example. You're caring for a patient. They are coughing. They have a fever. You don't know what's wrong with them. Do they have SARS? Do they have a common cold? Do they have influenza? Do they have whooping cough? You don't know. But if you have to have contact with that patient, face-to-face contact within handshaking distance, then you need to protect yourself. Remember, your number one responsibility, to protect yourself and to protect your family, that you don't get saliva on you, that you take it home to your family, that you spread it to other healthcare workers. That's what happened in Ontario. Body substance precautions that we follow here at MetroHealth Medical Center requires that it be practiced by every healthcare worker for every patient, regardless of diagnosis. Now, how do you transcend between body substance precautions and the precautionary principle? Well, basically, you take ownership of it yourself. You have to decide, I'm going to first protect myself. And in so doing, I will protect my family. And you're going to be protecting the patient. You know, a few years ago, my wife had B-cell lymphoma. She's in remission now, but at one time, her white count dropped to 300. She was up in the oncology unit. I saw healthcare workers come in. Some washed their hands, some didn't. Some said they did it out in the hallway. I'm asking you that if you care for your patients, you wash your hands in the room so they know that you care for them. SARS gave us an example of what can happen in an epidemic. How is SARS spread? SARS is spread by contact, just like C. diff, VRE, MRSA. It's also spread by droplets, like meningococcal meningitis, and by whooping cough. If you're caring for a patient, don't wait for a report that they have such and such. Take those precautions immediately. Yes, we will put the patients in isolation if we suspect C. diff, for example, if they have diarrhea. But if you're caring for a patient and you know that they have diarrhea, take those precautions now before the sign goes up. Notify someone that they need to have a sign put up if they're in rule out. In other words, take ownership of it yourself.
Hi, I'm Jen Conti from here at MetroHealth Medical Center. I'm part of the Infection Control Department. In the Infection Control Department, we monitor hospital-acquired infections. We do surveillance on the units, and we act as a resource for employees here at Metro to provide them information about communicable diseases and ways to prevent hospital-acquired infections. Now we'll talk about some interesting facts about hand hygiene. For example, did you know that only 68% of people wash their hands after using the restroom? And nosocomial infections affect 1 out of 10 people who are hospitalized. This accounts for over 100,000 deaths annually. Nosocomial infections cost an estimated $7 billion per year in the U.S. And hand hygiene compliance rates in the hospitals are around 40%. Hand hygiene is the single most effective way in preventing nosocomial infections. Hand hygiene is the cornerstone of infection prevention. You want to be sure to decontaminate your hands before entering your patient's room, whether it's using the hand hygiene product or using soap and water to wash your hands. You want to do that before entering the patient's room, even if you're not going to touch the patient. If you're going to touch the bed rail or the bedside table or the patient, you always want to wash your hands. You also want to decontaminate after touching the patient, before you move on to touch your next patient or go to touch your chart or go sit at the nursing station and do some documentation. You need to take off your gloves and then wash your hands, or use the alcohol-based product. Wash your hands with soap and water before preparing or eating food. Wash your hands after using the restroom. You want to use soap and water when you suspect a patient has diarrhea. You may not know if they have C. diff or not, but you want to use the soap and water. Using the Purell is not effective in C. diff. When washing your hands with soap and water, you want to turn on the water and adjust the temperature to your liking. Apply a proper amount of soap. 1 pump is usually sufficient. You want to wash your hands for 15 seconds and enough time to sing happy birthday. You want to wash all surfaces of your hand, the backs, the fronts. Pay special attention to your fingernail beds and around your rings. Rinse hands with water and dry thoroughly. Use your paper towel to shut off the faucet. How is the alcohol-based sanitizer rub used? You want to depress the pump once and cover all surfaces of your hands. Rub vigorously until dry and continue rubbing your hands together until the product is dry. This usually takes about 15 or 20 seconds. You want to make sure your hands are completely dry prior to putting on gloves or beginning any tasks. Now again, this hand hygiene product, you don't want to use it if your hands are contaminated with soil from a patient, any type of contact with a wet surface or anything. You want to use soap and water if your hands are visibly contaminated. If you've just had casual contact with the patient and you leave the room, then that's a great time to use the alcohol product.
As you recall, back a few years ago, SARS hit in Canada. Let me tell you about a story about one healthcare worker, a doctor, who was exposed to SARS. And this is his story. When my temperature hit 39 degrees, I called the infectious disease consultant on call and was advised to come in the next day for assessment. I spent the rest of the day in bed in the basement with a sense of unreality. He had isolated himself from his family after he had been exposed caring for patients with SARS. Worrying about my family as the fever mounted. Had I infected my wife? Who would look after my children if she became ill? What if the children became infected? I would not want to survive only to know that I had caused the death of a loved one in my immediate family. This physician was scared. You have to decide, I'm going to first protect myself. And in so doing, I will protect my family, unlike that doctor that was worried that his family was going to get SARS. And you're going to be protecting the patient. Take ownership of it yourself. And that's how you're going to turn body substance precautions, which is required by everyone that cares for patients, into the precautionary principle. You take ownership of it yourself. And you will protect yourself. You will protect your family. You will protect your patients. Thank you.